In 5 years.
About 10. 10:30. Oh, no. You're right. No. You're right. 5. Okay, ended about 8:30. So, it took us a while.
The department nominated me to this giant application. It was like 80 pages. People to write letters. Books for all over yours. And then you have traditional evaluations, departmental, and at the disease level.
Good morning.
It's a lot of work. I mean, I know it's going to get it, no question. But just forever. Application, I'm not doing it.
Not too bad.
Literally like everything.
Everything getting older.
Yeah,
It's
it's a
not
lot
so
easier.
easy.
Yeah, so you're going to be recorded, and you're going to be like people throughout the Northwest.
That's awesome.
Yeah, they don't live here, but they log on.
Cool.
Yeah, it's very cool. Did you get your coffee, Scott?
I had coffee before I left the house.
The house, you live with house.
Well, I live
Oh, you live there.
half an hour north.
Gotcha.
Although maybe I should start calling my hotels the house. Might diminish the way I feel sometimes.
Someone was telling me that they use, so I was thinking about looking out. They have those like videos and they show them on the laptop and you can help.
Oh, really? That's aggressive.
I always bring clothes to like use at the gym and then I never got it.
I did the same
I don't know
thing.
why I bring it.
I know. I'm not getting mad that I brought it.
I stopped kidding myself years ago.
It's hard on the road.
I was good on the band. I was good at work very fitness a lot. At work, you are killed if you guys have. You come out and you burn like 7.5 hours.
What is that?
You, and they kill you during the workout, but you come out and you burn like 700 calories.
What kind of workout?
It's cool, like CrossFit, like
Okay.
interval stuff, it's treadmills and the rower and weights and
Get your heart rate up real fast and
just
it goes
down, back up.
Yeah. Yeah.
It works. Like I can go like consecutively for 2 weeks and I've lost weight.
Wow.
I'm sorry. It's just and it's efficient. Like it's an hour and you're 50 minutes.
Friday's the day.
Friday? Why Friday?
I mean, you're dead, but you're like, I mean, I don't know. I mean, you're not.
It had like
Still
some.
go back to work.
Yeah.
So, and then the problem is I get sick, like with some virus my kids gave me, and then I like can't go. 'Cause I
But
can't
he has
breathe.
something on his mouth because I can't swallow.
Oh, to go home you go.
Yeah, I might add.
Who's on?
I brought him to Not every time, but most, especially if it's lower respiratory tract. So,
I don't know.
yeah, she's the ER.
You still working nights?
No, he works mostly all days.
I got.
He got promoted, so that was part of why I didn't come here. As he was looking,
Yes, oh, that call was that.
we went back to
Came back to
Florida.
zero.
What?
Zero carton.
A call or
No.
a inpatient?
Outpatients. We're senior. And it was like, oh, it's likely down like.
Oh, but you saw it in clinic.
Yeah.
Days.
I was like, I mean,
Oh my gosh.
zero compliments.
That means that's real, right? I mean, it's,
Yeah.
Got
so where's
and when he was hired, he didn't have one. He was like hired in this bubble where like everyone before him got it, and everyone after him got it. And so
That's
they
microwavable.
got rid of that, and he had like almost $100,000.
Feels microwave taste.
From medical school, or maybe it was like $80,000. Part of it is there's no incentive to pay it faster because the interest
There
rates
was
are
an
so.
inpatient I saw.
It's like 1.2.
For a 2-year-old who had
Because they make them like
with osteomyelitis
loans.
like
There's
6
no
months ago.
like why
Or
pay
like a year ago.
faster?
Yeah, it was down the center.
And then now has like a
So-
recurrential
You may
abscess.
as well use your money and invest in something else.
And then
He was paying, we paid maybe like
I'm
$1,000.
like, let's send it off to
to
me
make the pop, but
first,
they,
and like, you know,
so the way this program works now, you
compliment and all
get a ton
stuff.
of- I think we
Because
had
the IgG came back in 47.
like 30 or something like
What?
that. And then they match it, and then
You're
it
like, all of it.
ends
You're
up
like,
being,
we weren't
it like
expecting
pays
that.
down a substantial amount all at once. And then it'll do
It's
that.
like
every
otherwise, like a
year.
healthy
You
2-year-old.
have to have the
He's not
money
like,
up front.
That's
So
not
we
not
can
good.
only
You
use
cannot predict
$20
the outcome.
to pull it down.
That's why I realized that Troy never say he's alive.
He does. He's supposed to be like
You just order it.
so the 20 or 90
compliment what was
times.
wrong with the
But
patient. What
he'll
did they have?
do shifts.
So she
Usually
had
he'll do, like,
one
every few
severe
months, he'll do,
pneumonia.
like, 2 in a row, and usually
Period.
overnight, because that's where there's a need.
Pneumonia, pleural effusion,
And then,
hospitalization,
but like,
Oh,
he does
like
it in
severe.
the state case. So a lot of
It's
people,
only one
An
episode.
adult?
they
No, it's 18
get
months old.
sort of,
Oh, that's not
he
normal.
does it in the leadership.
Yeah,
team,
that's
and
not
he's
normal,
really-
but I mean, it's one
and he's
normal.
still willing to, like,
Everybody
step up
could
and
be like,
to-
getting
Yeah,
shot.
but
And
he
it
like
keeps
keeps
him, like,
needing
in the,
needing ECMO. It's like
like, it keeps you so when people are
Walking.
complaining about things, you're actually like experiencing.
No, it's only when you.
Not just about somebody else.
Changes in our presentation.
I have another
Oh, this is him?
comment.
Sure.
I got another-
Drew,
Hi, Drew. Nice to meet you.
meet you. He'll help you with changes.
Okay.
a new one.
Yeah, she was 18-year-old.
What's new?
What's new?
You didn't go to Husky
Or one
game,
of
did you?
the
No,
house.
you know, that was CGD before the prophylaxis.
Oh,
He comes into all the,
he was not compliant.
just like the experiment was antibiotic.
Was he one of their patients?
No, I agree. You know, we're into about the 25th round, which is nice and close. Now we're on about the 30-yard line, so maybe the other end of the field might not be so hot. But, no, I like it, but don't even have the doctor there.
He comes in September. I like to work for him.
Although that's done with trial seasons or so expensive seats, you're pointing for a lot. Yeah.
You know this organism that you can see.
Well, how many people were up there?
That's right.
Oh,
In August.
people drifting in and out, maybe 50, 100,
Probably, I probably
you know, overall. I tell you, I saw one.
or is it ours there?
Yeah,
I'll tell you what he told me about himself.
Oh, okay, go ahead.
He has a book that he's, I should read a book.
He just couldn't.
No, you told me I saw it. I didn't hear
So he
that.
said, so this coming week,
He's studying computer science. Programming. No, he's not. He's actually
He's for his
his
college and his parents. He should
I would guess if he's going through Christie's.
Yeah, tell me. Yeah, but he's like now.
So,
Is he an ICU?
get it back.
It wasn't nice.
The obvious question is why is he selling it?
No worries.
Well, he's gonna take the money and run, but for his kids.
Why does it drop?
I'm realizing we're just not. He couldn't even take on my son all the time.
passion.
That's like doing big stuff, yes.
Yeah.
Just take it.
Another big paraphernalia.
You know, I know there's also like SARS and
I
stuff.
don't think they're worth billions of dollars.
I never knew that.
Just started getting out the Christmas stuff last night.
There's a kid who came into me.
Big going.
I was like growing up.
Wendy's.
Now it's like we're getting ESR this
Yeah.
year.
Yeah, it happened to me, one person made a switch and all of a sudden, only hard. It's like, good turnout.
So tell us, what do we have today?
Do you have clinic today?
You get all dressed up.
Clinic?
Have it?
Well, I got a meeting now.
Oh, do you?
No, I know.
Man.
Oh, like, what's going on with the origins? I know that
He's probably started $4 billion
kid and the combined kid who are they're both outstanding, right?
That's top.
One's for a lot.
Yeah.
Yeah, the space thing is tempting.
This guy wrote it. With him for
What else? What else?
a good story.
I don't know.
He's gonna do that underground tunnel.
Yeah, right.
Oh, I love the size of the project.
You want to
Yeah, that's really.
You know, how many hundreds of billions of dollars will that be? But,
Oh, is there more than a patient?
Yeah.
And you don't know that?
No, I
There's a
didn't.
new season.
Another one?
18.
21.
21 years.
You get Rolling Stone?
No, I don't.
I'm not telling my research. Talks about, they wanted it.
The music that much.
Yeah,
I don't.
yeah.
I do listen to it all the time. Driving my life crazy. So I have to move up and down all the time.
I didn't send it to the last section.
University of Southern Florida.
Nobody has a phone for
Well, it's just a hassle to drive in and down. I like to get
65.
Yes, he's so big. I try not to bombard people.
No.
So I don't know any. Have you come over?
Honestly,
Like, probably goes to 17 pounds.
Wow.
It's like,
I texted them.
Labor of love.
Hey,
Bill.
Good morning.
Everyone.
Bill, did you go to the game?
Found his voice at 5 a.m.
It's here. Did you go to the Husky game?
I actually missed it. We were down in
He rolls over
San
for
Diego
the
for
first
Thanksgiving, so
time.
good game.
Some of the kids.
What are we ranked now?
13. You know, if we could possibly crack it.
It's got to be a top 10 team.
And I get so really fast.
That's too bad.
Probably almost.
Well, when I went to Atlanta a few weeks ago, I slept in the same room.
You know, the other kids, most of them seem might be a little bit more.
Cried out.
No, I'm just
My cousin cried out.
or their word.
I mean,
Oh my god,
he's
scary.
like the 4 nights I was there. He's not really right.
We ended up 11 to 2. 10 to 2.
You cried about it.
No.
USC.
Yeah.
I was like, I don't care what age to hear a baby crying.
We're ranked behind USC.
So like to count to 5 minutes or 10 minutes or like.
Fair enough. Like just yesterday, he like, I put a rattle out and he like grabbed it. Yeah.
It's a lot.
December 11th.
Your brother?
Oh yeah.
One time up there.
This
Yeah. She was failing to thrive, but I didn't sit in okay, this is hilarious. She had worked all this hair, like straight up, and it won't go down. Like it bumped her down. Yeah, and he was really tired.
Yeah, he looks so different.
I know. Even after we were Smith, my friend had a
Yeah, it's Serafina, right? Oh, excuse me, that's one.
No, it's fine, I just stumbled over it. I checked. Because I was like,
Where are you? Good.
No, but if you
Pretty good.
Not too bad as yours.
Spring chicken.
Change it with the name then, or? Everybody find a seat.
Go ahead and get started. The word of the day is disorder. So last week we brought someone from San Diego to get some weather reorientation. The rest of the world was like, we went even further. We had someone come all the way from Florida to see what we deal with here in the winter. But thank you for coming all this way, Jennifer. So Jennifer Leiding, Associate Professor and Director of Multidisciplinary Immunology Service. You can read this as well as I from University of South Florida. Is going to talk this morning about neutrophil biology and diseases caused by dysregulated neutrophils. Thank you.
Good morning. I'm happy to always come visit friends in Seattle, so it's really not too much trouble for me. So I changed the slides a little bit. I know that you guys have handouts. I'm sorry for that, but that's just my personality and way of doing it. Most of them are the same, though. There's just maybe in a little different order. So the purpose of this talk is to go over neutrophil biology, just a little bit background, and then going over a lot of primary immune deficiency diseases that we see that can be caused by defects in neutrophils. And so I made this more of a case-based presentation, just because I think I learned better from that, and it's a little more exciting. And so there are some, multiple cases that are through this presentation. So just my disclosures, so I speak for Horizon and CSL Behring, and also consult for them, but neither of them should affect this presentation. So neutrophil interactions. So this slide is really mostly just intended to show that neutrophils, although part of the innate immune system, interact, as most immune cells do, with every other part of the immune system. And so there's interplay between neutrophils, CD8 T cells, CD4 T cells, Th17 T cells. And so when you have defects in what would be considered the neutrophil or neutrophil-specific defects, there's impacts on other parts of the immune system that we'll see as we work through this slide deck. So this is a little bit of time frame of ontogeny of granulocytes. So granulocytes are one of the largest populations of cells in the immune system, but they are different. They differentiate themselves from other leukocytes by their morphology. That's what defines them as granulocytes. And those features include a segmented nucleus and staining of specific granules that are present in the cytoplasm of granulocytes. The bone marrow is the principal hematopoietic organ in humans, but it doesn't start that way. So I have a little timeline that's at the bottom that talks about neutrophil ontogeny during human embryogenesis. So erythrocytes are found in the first 3 weeks of gestation. After that, the vascular system develops, and hematopoietic stem cells can reach other tissues through that vasculature system. At that point, the liver becomes the major hematopoietic organ, and that's usually around 6 weeks of gestation. And then we start seeing neutrophils as early as the first trimester. Around then, bone marrow becomes more active and takes over into the second trimester as a hematopoietic organ. When that happens, neutrophil counts rise about fourfold. So by second trimester, we've got lots and lots of neutrophils hanging around. And then when the baby is born, counts stabilize in the first 48 to 72 hours of life. But it isn't that unusual to see lower neutrophil counts, if you measure blood spots like the second the baby is born, because they haven't transitioned. So there's also qualitative neutrophil defects in newborns, and this has been well described as late as the early 90s. And these include adhesion defects and quantitative defects. So there are low levels of L-selectin and beta-2 integrins, which are found on the surface of neutrophils. L-selectin can decrease even further in the first 72 hours of life, and it's low in the first few weeks of life. The effect is compounded by prematurity. So if a baby is not term, this decrease or deficiency in L-selectin can be weeks to months until the baby has reached corrected gestational age. There's also abnormal actin polymerization in the first few weeks of life and lower concentration of granular proteins. So there's some of this data has been used to surmise that maybe this is why infants are more susceptible to sepsis early in the first few weeks of life. I don't know that that's all totally panned out, but it certainly can affect it.
For most newborns, those are just transient?
It's all transient, correct. Yeah, transient. So diseases of neutrophils account for about 10 to 20% of all primary immunodeficiencies. And the common theme among them is severe susceptibility to recurrent bacterial and fungal infections, and these include infections of the respiratory tract, skin, oral cavity, and then deep infections like those in the liver or brain. And they're often isolated, meaning the infection itself is found in one organ. However, it can disseminate through the blood hematogenously. So you may see separate areas of infection, and they got there through the blood, but you don't often see just disseminated chronic infections. So this is my little slide of the life of a neutrophil, and this picture was taken straight out of the Abbas textbook. But basically, the neutrophil develops in the bone marrow, and then it needs to leave the bone marrow and circulate into the vasculature. It then tries to immigrate and join the tissue, and the picture of that is showing that at the bottom. So
There's
if you
a pointer on the...
Sure. You showed me, yeah. So if you look at this top part is red, which is blood flow, and then you've got your leukocyte, or for purposes of the talk, the neutrophil, which has to go through this really eloquent process, which I'm going to go into more detail in a later slide, but this very eloquent process of rolling and sort of slowing itself down along the endothelial surface, and then squeezing between two endothelial cells to get out into the tissue. And all of this occurs through chemokine and ligand interaction, and defects along this way can lead to different diseases that we're going to talk about. It then has to go into the tissue and kill whatever it is it's been attracted to kill, usually a pathogen, and then it has to die. So all of these steps can go wrong and lead to human disease. So also of importance is how the neutrophil travels. So, in the previous picture it shows this sort of, cascade of this rolling neutrophil. Unfortunately, it's not quite that easy. So neutrophils really kind of travel almost like an amoeba site. And if you remember, probably back from cell biology days, it does this through this actin cytoskeleton. And the actin cytoskeleton is made of F-actin and G-actin proteins that constantly are being built and torn down in order for the skeleton to organize itself, destroy itself, and reorganize itself as the neutrophil moves forward. And you can see the diagram is usually this forward moving, and then the tail end of the neutrophil is called the uropod. And different enzymes are at play in this, but leads to migration of the neutrophil in the blood, endothelial surface tissue. And then some of these adaptive proteins that are listed here, cophilin, which I have in these blue stars, and profilin, bind to G-actin and F-actin, respectively, to aid in this process. Okay, so diseases of the neutrophil. So this is a great review by Martin Kazai, who's at the Karolinski Institute, but this is a figure from his review that really is pretty comprehensive as far as not just number of neutrophil defects, but also where in this process they happen. From the egress from the bone marrow, the leaving it into the vasculature, and then killing defects and phagocytosis defects. So I broke this down into disorders of neutrophil quantity, chemotaxis, morphology, and function. And by no means are we going to go through all of these for purposes of time, but we'll hit some of them. So again, just to review a little bit, so neutrophils again are the dominant leukocyte population in humans. This is a good picture of a neutrophil. You can see the segmented nucleus. You can see some of these granules. A little hard to see, but and this is just seen on a peripheral smear. Like I said, they develop in the marrow, and they go through this process of development from promyelocyte to myelocyte to metamyelocyte to band form and then mature neutrophils. And this, explains why we see lots of bands when there's a huge neutrophil shift. When there's acute infection, you'll see more bands in the peripheral blood. They have 3 to 4 lobed nucleus, granular cytoplasm, and about 100 billion leave and enter the circulating blood every day. And then chemokines are the potent attractors to sites of infection. So neutropenia, so just quantitative issues, is defined as mild, moderate, or severe. Mild is an ANC or absolute neutrophil count of 1,000 to 1,500. Moderate is 500 to 1,000, and severe is less than 500. When you look at these numbers, your infection rate goes up as your neutrophil count goes down. So you're much more at risk if you have severe neutropenia versus mild neutropenia. Acute is significantly worse than chronic. Usually we see acute neutropenia in cancer patients who are receiving chemotherapy, and they usually become acutely neutropenic versus somebody who's chronically neutropenic. And then secondary causes are much more common than primary, which are usually iatrogenic or from medications such as chemotherapy. Okay, so the first case. So this is, and all of these are real patients that I take care of. So I'm not making any of them up. So this is a 23-month-old male with a 6-month history of recurrent mouth sores and mouth lesions. He had a history of umbilical cord infection that actually required surgery to debride it shortly after birth, and he had a history of multiple cutaneous infections. So he's referred to me. He has a CBC that's normal, other than he has an ANC of 0 at 23 months of age. But when I went back in his chart and looked at if blood work had been done at the time of surgery, it in fact had, and his ANC at 4 months of age was 1,800. So we have somebody who's become, although 1,800 is not completely normal, has become neutropenic in the first 2 years of life. So this is a case of cyclic neutropenia, and we found this in this boy. So cyclic neutropenia, you can see on the bottom picture, it's old, but it's a great picture, shows the neutrophil count, this oscillations of high and low, or I shouldn't say high, but normal and low, that happen about monthly. And your monocyte count follows in suit, so also will be high and low. So you see regular oscillations in the neutrophil count about every 21 days. During the nadir, there can be fever, malaise, stomatitis, lymphadenopathy, and soft tissue infections. There can be sepsis, although this is more rare. It usually manifests in childhood. It's autosomal dominant, and it's due to mutations in E-lane, which is the gene that encodes for neutrophil elastase. You often need serial CBCs or ANCs 2 to 3 days apart for 6 weeks to establish a diagnosis. And then, as I mentioned, other cell counts can cycle as well, and treatment is usually with recombinant GCSF or Neupogen, which is what this child received.
How does that mutation lead to that cyclic event?
So it's not completely understood because there are also, severe congenital neutropenia type 1, so I'm going to get into this. There are 4 types of severe congenital neutropenia. Type 1 is also caused by defects in E-lane. So you can have chronic neutropenia caused by the same mutations in the same gene or cyclic neutropenia. And there's not, as far as I know, a genotype-phenotype relationship, meaning that one mutation leads to cyclic versus congenital neutropenia. So I don't know the answer to that.
Are the neutrophils undergoing apoptosis then cyclically? Is that are they cleared because of
the theory is that what I have written here, that it disrupts neutrophil trafficking, but not so much about apoptosis. The other ones, the other mutations in some of the other genes, like SCN3 for HAX1 deficiency, HAX1 is a major inhibitor of apoptosis. So that is true for other of the defects, but I don't know that it is for E-lane.
When they have like an elastase mutation, is it accumulating within the cytoplasm, or what?
Is the elastase accumulating within the cytoplasm? I don't know the answer to that. I don't know. So, okay, so the other types are, like I said, 4 types of severe congenital neutropenia that I have listed here. Type 1 is still by far the most common, which is E-lane mutations, followed by type 3, which is HAX1 deficiency. It occurs in about 15% of those with congenital neutropenia. and is autosomal recessive. Type 4 is interesting because you see other somatic defects like cardiac and urogenital defects, and the genes are listed here. The way we diagnose this is obviously the patient's neutropenic and usually sick, but also with a bone marrow biopsy. So you will see arrest of myeloid development at different stages. You also can see it with a peripheral smear, and then CBC, and then molecular testing for the specific gene. And then treatment depends on the severity of the disease, but recombinant Neupogen is how we treat, or bone marrow transplantation if severe enough. So this is a review that I published a few months ago going over different congenital neutropenia disorders, and so I just included, not necessarily to go over each one, but there are many other types of congenital neutropenia, some of which we are not going to touch on, but the 4 types here. There's also X-linked congenital neutropenia caused by defects in the Wiskott-Aldrich syndrome protein, and then hypopigmentation disorders, and then a lot of other syndromes where neutropenia can be part of the spectrum of their disease.
If you use GM-CSF, what sort of level are you happy with? In other words, do they need like 800 to 1,000 to call them adequate?
So usually G-CSF. I've never used GM-CSF for this, but G-CSF, I like to have them as close to 1,000 as I can, but usually they'll have a huge bump after they receive the dose, and by the time they're due again, they sort of fall again. But as long as that trough is greater than 500, you're usually out of trouble. But if you can keep them closer to 1,000, it's
so if you can't, that's when you go on to transplant.
I think it's also based on the mutation and what the likelihood of this is that this is going to. If it's cyclic neutropenia, usually you can overcome it with Neupogen. I think if it's one of the congenital neutropenias, you're really thinking about going further to transplant.
Is the defect incomplete so that you can, with CSF, you can stimulate some cells to make more? Yeah, make
Not
more?
That I'm aware of. I don't think so. Not that I'm aware of.
But how do you get more cells out of a genetic defect then? How do you bypass it?
How do you bypass?
You would think every myeloid cell would be defective and you'd be stuck, so to speak.
I don't know how you if it's that it's got to be that it's not complete penetrance, so that you're able to overcome it to some degree with GCSF. Otherwise, it wouldn't overcome.
It wouldn't work.
Right. Okay. So the second case is a 2.5-year-old little girl who presented to, this actually happened when I was a resident. So I was hoping Alex Petrovic would be here because she took care of this child, and there's a lot more of the details than I do. But was a 2.5-year-old little girl who presented with MRSA bacteremia and had S1 vertebral osteomyelitis. She also had oculocutaneous albinism, and then had some neurologic symptoms that prompted them to get a lumbar puncture and had evidence of HLH in her CNS. So this is a case of Shiraya-Kagashi syndrome, which is characterized by recurrent cutaneous sinopulmonary infections with specific gram-negative and gram-positive organisms. There can be mild neutropenia or pretty severe neutropenia, and you have impaired neutrophil hemataxis. There's also abnormal NK and T-cell cytotoxicity because this is really a defect of actin polymerization and hemataxis. There's also progressive neurologic abnormalities, including the ones I have listed here: ataxia, seizures, palsies, and developmental delay. And then these patients are at very high risk of developing lymphoproliferative disease, or HLH, usually started by EBV or another one of the herpes viruses. And when that happens, really the only treatment at that point is transplant. But characteristically, when you look at these neutrophils, they have clumping of the granules. So you can see that with these big blue dots, and then the nucleus kind of clumps as well, but it's mostly the granules you're seeing that are clumping. They also have abnormal hair patterns, so this is a piece of hair. So in reality, what you have is melanin really throughout the hair shaft, and you have these clumps of melanocytes that occur in the hair, so the abnormal is on the left, that you can see with this defect. And it's, like I said, a killing and chemotactic defect. So other lysosomal trafficking disorders, which I'm not going to get into detail about, include Hermansky-Pudlak syndrome type 2 and Griscelli syndrome. Both of these have albinism as a feature of them. in some way, shape, or form. Gracelli tends to be a little less albinism, but lighter hair, lighter eyes, but not usually fully albinism, whereas Hermansky-Pudlak syndrome type 2 is typically oculocutaneous albinism. Okay, next case. So this is a 3-month-old male who presented with RSV bronchiolitis to us, which doesn't seem that impressive. But he had one episode for a perforated otitis in the past, which in his culture was positive for strep pneumo. So whenever I'm teaching our medical students or residents, this is not normal. You should not have a perforated otitis by 3 months of age. You probably shouldn't have any otitis by 3 months of age. Usually that doesn't happen until about 4 to 6 months. But the fact that he had it perforated was a little concerning. So he gets admitted for his RSV and has a white blood cell count of 80,000. So that's when they consult us, and he has leukocyte adhesion deficiency type 1. So LAD type 1 is characterized by recurrent necrotizing infections of the skin, perineum, and GI tract. You can see umphalitis in newborns, which is this infection of the umbilical stump. If your child has teeth, which of course this one did not, they will eventually develop periodontal disease and even retraction of the gum line and bone loss related to the neutrophil defect. And then the infections that they see and usually consist of gram-negative and gram-positive organisms. There's this characteristic absence of pus because neutrophils are not able to get to the site of location or the site of infection. There's neutrophilia present on the CBC, and then mutations are due to CD18, which is the neutrophil integrin responsible for anchoring the neutrophil to the endothelium. So this is our picture again that shows the rolling of the neutrophil. And so the beta-2 integrin is what's found on the surface of the neutrophil and binds to the surface of the endothelium to allow the neutrophil to slow down as it's rolling across the endothelial surface. So basically you have a problem where your neutrophils are stuck in your blood, so they can't get out to the site of infection to fight said infection. And these are usually life-threatening, and patients need to undergo bone marrow transplantation for cure. There are other types of LAD. LAD1 is by far the most common, which I just discussed, but there is LAD2 and LAD3. LAD2 is due to defects in CD15, which include some of the selectins that sit on the surface of the endothelium. And they have, there have only been a few cases described, but those patients, in addition to infectious susceptibility, have growth and mental retardation, hypotonia, dysmorphic features, and this characteristic Bombay blood type. And then Kindlin-3 in LAD3 is also responsible for some of the platelet aggregation that occurs, and so you can have bleeding diathesis in addition to the infectious susceptibility. But again, type 2 and 3 have only been described in handfuls of patients, mostly from consanguineous families.
This type, do you see all granulocytes with the same abnormality? So, for example, you see a high eosinophil count in LAD1?
I don't know that I've ever seen that in the patients that I've taken care of. Okay, and then the last defect in active polymerization I'm going to talk about is Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome, as we know, is X-linked recessive disease that have, I sort of highlighted the three major characteristics, which include eczema, thrombocytopenia, and small platelets. But patients are susceptible to lots of infections, chronic diarrhea, inflammatory bowel disease, and other hematologic disorders. Their immune phenotype, characteristically, if you're just doing a normal, regular immune workup, would include increased IgA and E levels, normal or reduced IgG and M, and then abnormal antibody responses to recall antigens. And what's interesting, before I get to that, so the defect in Wiskott-Aldrich is due to basically WASP not being able to bind correctly to ARP23, which leads to poor actin cytoskeleton reorganization. And that occurs through proteins I discussed on the side, including WIP, and then through this Rho family GTPases activates itself and leads to the binding of ARP23, which is one of the proteins responsible for that F-actin, G-actin polymerization that I showed earlier in the talk. So what's most interesting to me about Wiskott-Aldrich is that what I just classically talked about is defects in Wiskott-Aldrich syndrome protein, but there can be other mutations in the WASP gene that lead to other manifestations or other types of disease, including X-linked thrombocytopenia and X-linked neutropenia, which lead to different expressions of the WASP protein, and they all have different prognoses associated with them. So if you look at the most severe form, WASP, there's a very high likelihood of bleeding diathesis due to the thrombocytopenia and severe infections, and then even early onset malignancy and autoimmunity. Some of that continues with the other diseases, but their infectious susceptibility goes down, as does the bleeding diathesis to some degree. Okay. This is a new one, and this one's really cool because it just came out. So this cytoskeletal abnormality is in a gene called WDR1, a deficiency. Well, it's not the gene, it's a gene and protein. And is due, so WDR1 codes for AIP1. And AIP1 is one of these proteins that binds to the F-actin, sorry, the mouse went away, the F-actin component of the cytoskeleton. And so this was described out of the NIH in 3 families who had recurrent cytopulmonary infections, mostly from gram-positive and gram-negative organisms, UTIs, and then this characteristic oral stenosis. And you can see that in these 2 children, in which their oral orifice, or their mouth orifice, basically closes in on itself. And I think both of these kids were school age, maybe 5-ish, 6-ish, by the time this happened. And so you can also see on peripheral smears these very abnormal looking neutrophils, in which the nucleus is sort of extruding itself from the neutrophil, or kind of pseudopoding away. And like I said, this is a defect in AIP1, so it's leading to the cytoskeleton not being able to reorganize itself. And like I said, WDR1 codes for AIP1. AIP1 enhances activity of cophylin, promoting complete depolymerization of F-actin. And so once it's completely depolymerized, it can't build itself to rejoin the cytoskeleton. Okay, I'm moving on from the cytoskeletal defects. So case 4, so this is a 13-month-old Sudanese male, this is a true story, with 2 previous episodes of cellulitis. He developed high fever, emesis, and weakness. He shows up at his local ER, so his parents are actually both physicians. His mother is an internal medicine physician from Sudan, but didn't repeat her training in the US, so is not practicing. The father has repeated his training and is actually a nephrologist. So the little boy develops this episode of high fever, goes to his pediatrician, they put him on amoxicillin for otitis media. He starts getting sicker and sicker, has some weakness, they take him to an emergency room, and the emergency room doctor thankfully did a CT of the head, and he had a very large mass. They airlifted him to our center. He underwent a parietal craniotomy, and the cultures from that craniotomy, when they evacuated this lesion, consisted of MSSA. So this is a picture of his abscess, sitting right here. And so what was on the differential when, so we were not called initially. He was quite sick in the ICU, and infectious disease service was sort of following him. And one of the things that they were thinking highly about was chronic granulomatous disease, as they should, because it's an MSSA infection in the brain. And so they did a DHR, and they kept doing a DHR. They did it actually 3 times, and it continually kept coming back inconclusive. And our tech who does our DHR is actually very well trained under Tom Fleischer, who developed the DHR, so he's quite good at doing them. So I wasn't so much worried about the technique as the test itself. And so when we got involved, we looked at the DHR, and so, I'm going to show these, and then I'll go backwards. So we looked at the DHR, and so if you look at how a DHR is run, we talked about this a little bit last night, you isolate granulocytes based on their size and granularity. And so this is a healthy control up top. You can see that the largest, most granular sites are your granulocytes, or granular cells are your granulocytes. And so they gate on that, and then they stimulate these cells with PMA and look for fluorescence after superoxide has been generated. And so you can see in the normal control that peak fluoresces nicely once the stimulation has occurred. In our patient, so you can see that they have a lot of trouble isolating the granulocytes, right? Your granulocyte population, there's not really 2 populations here. Now what's below your granulocyte population is your lymphocyte population, because they are also big cells, but they are not granular. So they usually sit sort of right below it. And so his granulocyte population was falling into his lymphocyte population. And in fact, when he did this DHR, they kept getting all these peaks because it was a dirty specimen. It wasn't pure granulocytes. So what this told me, as soon as I saw this, is your granulocytes aren't granular, right? So that's your problem. They're not granular. That's why they're falling into this pattern. And so if you do a peripheral smear, which costs, I don't know, $3, you can see the problem. And so that, in fact, that is what we did. So this is the picture of the neutrophil I showed earlier, where you can see, or I'm sorry, this is the picture of the neutrophil I showed earlier, where you can see the segmented nucleus and all these granules. And you can see in these neutrophils, there are no granules present, or none that can be visualized. So this is a granular defect, otherwise called specific granule deficiency. And so neutrophil granules consist of primary granules and secondary granules. They are based on their staining patterns. So primary granules are azurophilic, whereas secondary granules are not. And so they also stain for different enzymes that are responsible for killing of organisms within the neutrophil or outside the neutrophil. So this is a case of specific granule deficiency. It's due to absence of primary or secondary granules. You see this abnormal bilobed nuclei. They have deficiency in microbicidal proteins, recurrent bacterial and fungal infections with Pseudomonas and Candida. It's autosomal recessive. It's a myeloid transcription factor, so defects in CEBP epsilon, which is a myeloid transcription factor. And the way this is diagnosed is with microscopy. You can stain for these different enzymes, and then also molecular testing for the genetic defect. And treatment, really, as to date, is supportive. There's really only been a few cases published, but is supportive, including prophylactic antibiotics. So this child had this mutation. The other thing that is interesting about specific granule deficiency is it's more common in the Mediterranean basin. So people who are from that area of the world. So the fact that this family was Sudanese sort of went along with where they were from. It's also more common in consanguineous families, and they in fact are consanguineous. And they so this led to then the diagnosis of his younger brother, who also has this disease. So I have now a family with this mutation, and they both are doing very well on just prophylactic antibiotics. We talked about transplantation, but have not been able to identify a proper donor, so we haven't pursued that route for now, but they're doing quite well. Yep.
I understand the Pseudomonas problem, but why do they have Candida? Why do they have Candida infection?
So there's the same. It's the same concept. Even CGD patients can have problems with Candida. It's typically isolated Candida, but there is some neutrophil activity against Candida as far as neutrophil killing. It's not all T-cell specific, which is what I think we're all kind of trained to think. But there is some neutrophil activity against Candida. But it's usually, whenever we see Candida infections in neutrophil disorders, it's invasive, isolated Candida. It's not mucocutaneous, like you would see in some of the other innate defects. So to go backwards, because I kind of messed this up a little bit, I want to hit the DHR assay a little bit, just because we're going to talk about it more in a few minutes. How I explain this, where we isolate these granulocytes, we then tag granulocytes with a fluorescent tag, stimulate them, and look for fluorescence of that population, is how a DHR is run, and this is diagnostic for CGD. We used to use the nitrobilutretrazolium test, which is what is depicted here, which uses similar methodology in that you are looking for a color change after stimulation with PMA. However, it's relying on a person to read a slide and note that color change, and it's a purely qualitative test. You don't get a number or readout or any quantity of that can guide how much superoxide you're making. But we'll get to CGD in a minute. I just wanted to make sure I covered that. Now this is where we're going to get to it. So this case is actually a patient that I diagnosed about 10 days ago, who is a 3-year-old little boy who presented to an outside facility with cough for 1 month and a chest wall mass. He had a history of several pneumonias in the past that were confirmed by chest x-ray and treated with just antibiotics alone. And he's also a little small for age, but is not, I wouldn't call failure to thrive. This mass was biopsied on the chest wall, and the culture grew aspergillus. He also has a family history. His mother has rheumatoid arthritis, and he has a healthy twin sister and a healthy 7-month-old brother. So this is his CT. So you can see this giant lesion, obviously in the chest, which is extended into the chest wall. And this is all Aspergillus. I don't know the species yet. We're still working on that. And this is his DHR. So we did this right away because he had CGD based on the infection he had. And again, these are the granulocytes being isolated. This is our control over on the right, and the patient is on the left. And you can see that the peak does not fluoresce after stimulation, whereas in the healthy control it does, and this is consistent with X-linked CGD. We also did mother, concerned that mother might be a carrier for this disease. And you can see, again, the stimulated portion. Mother has 2 populations of cells. So we went over this last night, but this is a concept called lionization, where every cell in a female's body expresses one X versus another. And in her, usually that's roughly about 50-50. And so in mom, she is expressing one population that is mutated and another population that is not mutated, which makes her a carrier of X-linked CGD. So I actually got news right after I landed yesterday that the 7-month-old brother also has CGD. So we now have 2 little boys in one family, which is not good. So just to go over CGD, this is my depiction of a giant cell. And then the lysosome membrane within the giant cell is this light blue. And so you see this NADPH oxidase complex come together once the cell has been stimulated. And the complex consists of 5 major proteins, really 6, but 5 that matter for purposes of this talk, including P67, P40, P47, GP91, and P22. And mutations in any of those 5 proteins will give you CGD. So on the surface of the phagous lysosome, the NADPH donates one of its hydrogens and leads to the production of superoxide. Ultimately, what starts as hydrogen peroxide, then bleach, which ultimately leads to superoxide production. So again, mutations in any 5 of these proteins leads to CGD. So types of CGD, so X-linked is by far the most common in about 70% of patients. Women, or the mothers of these boys, are often carriers of the disease, but not always. There can be de novo mutations. And then there are recessive types of CGD, including P47 FOX deficiency, which is the most common type of recessive CGD, followed by P67 and P22. So this is a more comprehensive list of types of infections in a review that we wrote in patients with CGD. This list is growing and growing every day, so it's not, again, probably not complete at this point. But what all of these infections have in common is that they are all catalase-positive organisms, and that is what CGD patients are susceptible to. The big infections that we hear about in North America include staph, Burkholderia, which used to be called Pseudomonas cepacia. We see Serratia, Nocardia, and Aspergillus. But there can be other molds, other fungus, and some of the Candida, like we talked about, that can be associated with CGD. And then just to touch on what we were discussing last night, some of the newer organisms that have been found, this Chromobacterium and Francisella, are causes of sepsis, and these are organisms that are found in brackish water. So that's brackish or fresh water. So that's why we tell CGD patients that they should not be swimming in freshwater ponds or rivers. So inflammatory manifestations are also a major part of this disease, and I've just listed some of them here. Chronic colitis is probably the most common out of all of this. We see this in about somewhere between 35 to 50% of CGD patients will develop a Crohn's-like colitis. We also see granulomatous lung disease, so granulomas forming in the lung. They also can form on the skin and other sites, and that can lead to chronic respiratory insufficiency. We see changes in the liver, and this is usually following some sort of liver infection like an abscess. But we will see non-regenerative hyperplasia, portal hypertension, chronic transaminase elevation. There can be chorioretinal lesions. There can be really this stomatitis, which is sort of reminiscent of the Crohn's, where you can go mouth to anus of inflammation. There can be photosensitivity rashes, again, granulomas of the skin, and then specific predisposition to diabetes and kidney disease in those who have P47 deficiency. Yes? Oh, no. Sorry.
Before I stopped, I had a question.
Sure.
Back to the specific.
Granule deficiency.
So if you lack eosinophilic granules, you basically get the same clinical picture since you don't.
Correct. Yeah, they don't specify that. They don't isolate the difference between the two in the disease because it hasn't been reported enough to know exactly which granules are deficient, so to speak. It really is a combination of the two. Okay. So hyperinflammation in CGD is, these are clinical examples in which we see this and is really due to an overactive host response to infectious agents, but can also be overactive just in general. And so all of these are great published examples of this hyperinflammation, so nocardia, pneumonia, mulch pneumonitis, and I'm going to go over some of these in a minute. Chronic colitis, wound dehiscence, and then there also can be a predisposition just to autoimmunity in general, especially in carriers. So we see a higher predisposition of discoid lupus in carriers, and then some of the other rheumatologic diseases. So it's interesting that in my family the mother had rheumatoid arthritis, which I'm sure is related to the fact that she's a carrier. So this is showing corticosteroids in the treatment of severe nocardia. So these are two patients running vertically. So if you look on the left, this is A, B, and C is one patient, and then D, E, and F is one patient. And these were all patients who had severe nocardia pneumonia that were failing standard antimicrobial aggressive treatment. And there was this idea to give them steroids to calm down the inflammatory reaction surrounding the nocardia, which in fact worked. So giving steroids in addition to proper antimicrobials led to resolution of these infections in these two patients. So this is the story of mulch pneumonitis. So I told you this overactive response to infection, but it's also the infectious agent itself. So mulch pneumonitis is the development of a pneumonitis picture within 1 to 10 days of some major exposure to aspergillus. And it's usually something like, mulching the garden, raking leaves, going on a hayride, cleaning the gutters. And these are 6 different patients who presented within 1 to 10 days of doing such an activity, who were found to have aspergillus in their bronchoscopy specimens, who developed this overwhelming pneumonitis. And it's very reminiscent of hypersensitivity pneumonitis. And so if you look at, like I said, the large exposures, there's a short incubation period, and symptoms overlap with other syndromes. You see a diffuse pattern on chest x-ray that's indicative of the hyperinflammatory host response. And you have to treat these patients with steroids in addition to antimicrobials or they will die. So that's the ultimate thing that happens. And what's interesting is when this is looked at in murine models, it's not necessarily infection with aspergillus, so to speak. There can be this response just to the inhalation of aspergillus spores. So it's you will see that just, it's not quote-unquote infection in the sense that it's not an abscess or a loculated lesion. It's really just the inflammatory response to the presence of the aspergillus itself. And so the calming of that inflammatory response is very important. So this is a paper, this is actually the first paper I published as a fellow, looking at staph liver abscesses in CGD patients. And so this is opposite of our nocardia story. The patients are running horizontally. So A, B, C, and D is one patient on the top and the bottom. And these were patients who had staph liver abscesses that were considered inoperable, either were in a very bad location or were literally the size of their liver, so you'd be removing almost their entire liver, and were being treated aggressively with IV antibiotics without improvement. And so we chose to give steroids in these patients, and this led to great clinical improvement, and in all of the patients that we reported, were able to avoid excisional surgery. So steroids were used at a dose of about 1 per kilo and then tapered really probably even longer than 2 to 3 weeks, more probably like 6 to 12 weeks, but a very slow taper. If you taper too fast, you have recurrence of disease. This is a picture of poor wounds healing. So this is a boy with nocardia osteomyelitis of the scapula, and you can see 3 months post-op, his wound is just completely pissing still. You sprinkle him with a little steroids and it completely closes, which is counterintuitive to what our surgery friends say, and they get very uncomfortable when you suggest this, but usually works and does the trick. So inflammatory bowel disease in CGD is quite frequent, as I discussed. This slide is really just showing you that there's not a symptom that is specific to CGD colitis. It really, patients symptomatically look like everybody else. So you see frequent abdominal pain, diarrhea, constipation. There can be this growth disturbance, which is pretty classic in CGD colitis. So you will see very small children. They will not be growing. They'll grow out, but not up. So usually their height is affected. And all of these can even precede the development of the diagnosis by years. Okay, so what's new with CGD? So we still know about triple prophylaxis, which is still considered standard and includes antibiotics such as Bactrim, antifungals such as itraconazole and interferon gamma. There's also the story of PPAR gamma agonists. So this has been recently published, mostly in mice. There's some human data. And so I'm going to show you that a little bit. So this is out of Don Bratton's group in Denver using pioglitazone to restore phagocyte mitochondrial ROS and bacterial cytal capacity. PPAR gamma agonists such as pioglitazone are approved for the treatment of type 2 diabetes. And their mechanism is that they alter cellular metabolism and they can heighten ROS production. So they had showed in this paper that short-term treatment of X-linked CGD mice led to enhanced ROS production from the blood of neutrophils and inflammatory macrophages recruited to tissues, and mitochondria were identified as the source of the ROS. And again, this was in mice. So this is showing DHRs of the mice. I think the bottom part is what I would concentrate on. And you can see that the wild-type vehicle mice or the wild-type pioglitazone mice were that they had a heightened DHR after the receipt of pioglitazone. Okay, what else? So inflammatory complications are still the major cause of morbidity, and we see a big problem with that still. How to treat it is not well understood. We usually rely quite heavily on steroids, which they themselves have a lot of problems associated with them. And there's not a magic bullet for the treatment of inflammatory disease in CGD, at least as of yet. Survival is based on your residual superoxide amount. And then transplant has become more of a more viable option, especially with reduced intensity conditioning. And then there are gene therapy trials that are now open, or reopen, I should say, for X-linked CGD specifically.
If the neutrophil and the monocyte are both defective, as you showed us, what cell type is causing the inflammatory complication?
That's a very good question.
Yeah.
So I think that it has been shown that so there are probably about 15 very eloquent papers that look at different cells and different cytokines related to CGD inflammation, and all of them sound like they're the right answer. None of them are. So most of it has concentrated on the neutrophil itself and upregulation of neutrophil specific cytokines, because you can imagine if you have an acute infection, your marrow is still pushing out neutrophils because they're not doing their job. So there's this constant positive feedback loop. So there's some of that. There's just this constant drive for neutrophil trafficking. There's also a lot of literature that shows that neutrophils are not dying appropriately, and that there's not efferocytosis of the neutrophils. So they're not getting eaten up. Their debris is hanging around at the site of infection, and so that can then stimulate other cells to come in and create havoc because it's sort of cellular debris that's sitting there. And then there have been some other literature, other pieces of literature that looked at other cell types, and including T cells, even complement B cells in CGD, and there's little defects, sort of nuances found in each of them, but none of them have been kind of the magic bullet to explain every manifestation.
So if you just biopsy that inflammatory mass, what do you
You'll
see?
see a lot of neutrophils. You'll see a lot of neutrophils. Okay. So this was a little bit of what we touched on last night, but this slide was not in the deck that I used. And this is survival based on genotype and ROS expression. And so this is a great picture from Doug Coons' paper that shows that if you have a mutation, specific types of mutations, primarily in this transmembrane portion, which are the bases 1 to 310, you have higher ROS production. And these are usually missense mutations. And this is specific for GP91. I should have clarified that. If you have mutations that are in the cytoplasmic part, these typically consist of nonsense, deletion, splice, or frame shift mutations, and all have lower amounts of ROS production. And as we discussed last night, the ROS production itself will dictate your prognosis. And so that was done in more of the data within this paper, in which they were able to place patients, if you look at the upper left part, into quartiles, and these quartiles were based on the amount of superoxide that you were making. So if you look at this mouse keeps disappearing, the mean superoxide in quartile 1, you're around 0.6, 1.32 for 2, 2.2 for 3, and 7.4 for 4. And so based on these quartiles, they were able to show in this bottom graph the likelihood of surviving based on that quartile. So if you were in quartile 4 or 3, your overall survival, was much higher into adulthood than if you were in quartile 1. Now these particular quartiles then correlated with specific genetic mutations. So if you look over here at this part of the graph, quartile 1 consisted of 56 patients, and it tells you the breakdown. 51 of those had GP91 FOX deficiency, 44 of those 51 had the more deleterious mutations, 7 had missense mutations, and then it goes, and so forth. So quartile 4 is primarily compromised of the recessives. There was 57 patients in all, 32 of them had P47 FOX deficiency. So our X-links are doing worse and have a worse prognosis. That is completely based on their genotype and the low amount of superoxide that they are making, which correlates with their genetic mutation. And this answers the question, which we all anecdotally had thought, that recessives do better. And they do, but they do better because they're making more superoxide. Okay, so this is my conclusion slide. So neutrophil disorders include disorders of quantity, morphology, migration, and function, and bacterial and fungal infections are the hallmark of neutrophil disorders. And a CBC itself can be incredibly informative, as can a peripheral smear. And so I would advocate that we start with that, and if that's not as helpful, then move on to more functional testing. And that is all I have. I threw in the last this rack thing, which I'm sure is in your handout, and I think we have a couple minutes, so I can go over it if you'd like. But it is basically, I get asked about rack a lot because it's in this NADPH complex, but it doesn't cause CUD. So what is it that rack really does? So it's a cause of, it's sort of the worst, in my mind, kind of worst of both worlds, because it leads to a neutrophil immune deficiency syndrome that looks like CGD, but also looks like SCID. And so 3 patients have been described to date whose clinical manifestations include perirectal abscesses, delayed separation of umbilical cord, absence of pus, and poor wound healing. And then their immune phenotype included neutrophilia, low numbers of T cells, increased memory CD4 cells, and then low tracks on the SCID newborn screening. So the most recent patient that's been published in this Jackie paper was picked up by newborn screening in Wisconsin when it first began. It was one of the first patients they screened and actually had a RAC mutation. So the patient ended up having many of these manifestations, but in addition to the neutrophil defect, had SCID. And I think that patient has now been successfully transplanted. So with that, I will go backwards and show my acknowledgments. So a lot of these cases were co-managed by myself and Alex Petrovic before she moved here, and then our group at USF, and then I always have to thank Steve Holland, who was and remains my mentor, and some of the folks at the NIH who have treated some of the patients I discussed here. So I'd be happy to take any questions at this point, or more questions.
Just a question about using steroid to kind of manage the hyperinflammation part. I mean, I saw like all the cases presented is that people who cannot have a conventional therapy with antibiotic or cannot get the abscess drained. Is that something that you have to go through first before considering prednisone, or you can start right away with prednisone?
I think some of it is bug specific, and some of it is trial, like you discussed. So a lot of the folks who do this are hesitant to do it in other bugs because it's probably specific to the organism to some degree. As far as the inflammatory response. And I think you have to do, your college try of antimicrobials. If you're seeing an abscess, though, like, for example, the liver that's taking up the entire liver, you're kind of pushed in the corner as to what you're going to do. It's also important to make sure that you know your bug. So all of the patients, for example, in the liver story had percutaneous drainage. And so they at least had whatever was liquid could be drained and decrease the infection burden in that regard. And then we had a culture. So we proved everybody had Staph aureus. So I think you have to do that. And if some of it can be surgically removed, you still should think about it. In the case of the liver patients, they couldn't be because it was inoperable. One of the patients in that series actually was sitting on like the portal vein, and the surgeons were like, "We're going nowhere near that. It was encompassing the portal vein." And then, you know, in those cases, you really don't have a choice, and you're going to go to steroids earlier. But I would advocate that you give yourself some time and kind of discuss the different types of management that you could proceed with. And really, you need to know your bug. You shouldn't just do this blindly. And it also is in addition to antimicrobials. And it is de-escalated on therapy. So that's important to remember, that it's an adjuvant, it's not a replacement.
That last defect you discussed, RAC2,
Yeah.
it sounds like that's a central protein both for T cell development and neutrophil development. Sounds like it's virtually a fatal defect to be born with.
Well, it's only been 3 patients, and I think Dan and Bruce is the one who reported the first 2. I think they died, and then the last patient was Wisconsin, and they were transplanted. So, I mean, obviously if you have SCED, that's fatal in and of itself, but to have a neutrophil defect on top of it complicates the whole problem. But definitely, I would say is a disease, at least in the 3 cases that have been published, that needs to go to transplant, is not consistent with living without a bone marrow transplantation. So.
You had one slide up there where the cells were chemotactically abnormal to, I think, FMLP, but not to something else. Why is that? I mean, you would think once you stimulate the cytoskeletal mechanism, it either works or it doesn't.
I don't think anything in neutrophil biology is all or none. So it's probably, I don't remember what slide you're referring to, but
back a couple.
I don't know. My guess is that what you're referring to is that there's some function of but not all. I don't think you rarely see an all or none phenomenon. There's some penetrance or some ability to get through. Sometimes even with higher doses of things.
That's the case. But with RAC2, there is the oxidative burst defect is only manifested with FMLP stimulation, not with PMA animation stimulation. So oxidative burst with PMA animation stimulation is normal in that defect, but FMLP stimulation is abnormal. It's the only way you pick up the oxidative burst defect in RAC2.
Maybe that's what you were referring to.
So it's not that's not a trafficking defect. It's the oxidative burst defect in that one. I mean, that may be, I don't know what you're. So not to sort of dwell on RAC2, but I think the biology is super interesting. Is there anything new known about the mechanism in that causes the T cell defect? Why does RAC2 cause a T cell defect? Is it purely a trafficking problem?
That's my guess, but I don't know. I haven't seen anything new. So I looked, a few weeks ago as I was creating this presentation.
Do the mice have a T cell defect?
Yeah, they do.
The RAC2 mice?
Because when the first one came in Wisconsin, it's like, this is supposed to be a neutrophil defect, but if you look at the mouse model, they have a T cell defect. So.
Do you use antibiotics or prednisone rather in severe pneumonia in general?
In immunocompetent.
Well, no, I thought the pendulum was swinging back to using steroids with pneumonia and you're running pneumonias that are severe.
I mean, I think I'm mostly a pediatrician, so I see mostly children. So they don't have, all the adult kind of emphysema and COPD and that sort of stuff when they're getting pneumonia. But I mean, we don't typically use typically use steroids for like a community-acquired pneumonia that's outpatient based. I think if somebody's dying in the ICU on an oscillator from respiratory failure from pneumonia, then we use steroids. But that has a lot more to do with like multi-organ compromise and things like that.
Well, yeah, there was a recent meta-analysis that suggests the benefit of that in routine pneumonia.
Sure.
When you see one of these kids in consult and you suspect this, how fast can you get the diagnosis in your lab?
So it depends on how much Troy wants to help me. It depends on what we're looking for. So we can do a lot of our clinical lab at the hospital can do a lot of this sort of assays in house. But a lot of we don't do a lot of molecular. Really anything in-house. Some people are doing it, I don't trust the results, so I tend to send it out. So the molecular diagnoses take longer. but you don't often need that to start proceeding. But DHRs, for example, I get within 24 hours. Any of these other sort of kinds of assays we can get pretty quickly. Research-based assays, it's like calling people you know and asking what they can do for you and that sort of thing. Sort of phone a friend. That sort of stuff. And the molecular testing we send out. So I think that would be nice to have in-house. But the problem with, as most of you probably know, the problem with molecular and genetic testing isn't the testing itself, it's the analysis of the testing. And so you have to have somebody who has a lot of dedicated time for that and also expertise in it so that they don't miss it or get it wrong to provide that. So unfortunately, we don't have that at this point.
Any other questions? Thank you. That was learning
Oh yes, I know them well.
Oh yeah. T cells and
Well, and Jane and I had fun last week. We're like, it's okay. Yeah, it's like that. Because we didn't
amazing all the different like the HAE. Different mutation
What? Oh, really?
A couple of us trained in some more Clemenol.
Yeah, that's a good. Or just private store where.
So do you want to call him or go?
I think he's got a brand. You better get this one running.
I may have found something.
Updating.
Yeah, and then tell him his name. Mom's a pharmacist. So she's pretty sad. All right, man. Thank you very much.
I'll wait.
Do you need a ride?
I do.
Come a long way.
It's scary out there.
Yes, I will. Maybe.
Okay, so after 12-ish, you're free. Okay.
We can go right at that room right behind the elevator be good.
No worries. I'm sure. I was like, oh, I have to okay, thank you. Great. That sounds great. Yeah. So maybe we can meet for coffee and before the holiday. Is it? Yeah. Oh, really?
I was down there. Well, I wasn't there, but at another practice. Actually, where ours is now for 3 years. So I got to know.
So Alice and I talk a lot outside of but trying to figure out how best to analyze it without it getting better.
Are you back?
So you can stay here.
Yeah, it's interesting. So
I just want to make before I finish, I want to make sure you're okay with this category.
All right. Thank you Still have an email address we can use?
Yeah, I'll give you my personal.
Yeah, give me that. Right.
Or I'll just email it to you.
All right.
And then you can.
And then I'll schedule it on.
Yeah, I like to be on the phone.
Next week I can tell you is German.
Oh yeah. Yeah, we get to.
I'll get you my.
All right, sounds good.
Yeah. 2 weeks is pretty good for especially like the clinical climate.
So much of Thanksgiving in the rain, so I couldn't ski. It's killing me.
So it's good right now, though, right?
We've got 3 feet. So
that's what we got too.
It rained.
Yes.
Northgate. I guess we already had a big broadcast. Understood every word.
No.
He showed up.
Very beginning.
Yeah.
Correct. You were correct. She grew up to be
Showed up at the door. Dr. Allman, do you
Yeah, we met.
Oh, serious?
Yeah, we did.
Oh, that's right.
You done
That's
before.
Or even just sometimes our
Yeah, like,
and then we could
you should come somewhere.
yeah, we're going home this weekend. I'm here for. I was in Thailand.
I know. I was like, I also was
No weddings. I was like, the day this area, everywhere. Yeah. It was like 2.5 days of like partying, and like the food was not just all that it was like every meal was pretty all good time.
Yes, yeah. Orlando's gonna be a stretch.
I need to start looking at tickets. I'll let you know.
Yeah, let me know. I'm excited,
Yeah, exactly.
We could always just do like we could go one way. Yeah, there's a non-stop flight Thursday morning. I was looking at 8 a.m.
Yeah, let me know. Maybe I'll look at them first and then see
I know. Wait, is it still? No, I think it's still there.
Is it?
See you later.
But I got it.
Yeah, I need to do that. Yeah, I need to do that too.
Supposed to go upstairs.
I have a quick question. Because you had mentioned, I'm Christina, I'm one of the second year fellows at Jay. Nice to meet you. I just came back from maternity leave, so I apologize. I didn't make it dinner, but that's okay. One of my colleagues who's a hospitalist saw a child in the ED, and she got called, and she's like, I've never seen this before. I know it's I called ID, but it was, I think, maybe around a 1-month-old with it's weird. So should they just get referred to immunology?
They should at least get a little bit of workup.
Yeah, they should get a workup.
Your us?
Well, they could just tell us.
A smear. Is it a girl or a boy?
I don't know.
The other thing to worry about is XLA. They can present like that early. But,
Sponsorship?
although usually we'll turn on antibody. But,
Well,
yeah, that's the point. Yeah, yeah, I would at least do that. It's weird. I mean, you don't, if you think about like general pediatrics and or even control matter. I mean, you never see it before those. So when you're seeing it in that age group, I think people don't think about it because it's still a pediatric problem, but you shouldn't be seeing otitis that early. They just don't, I don't really know why they don't get it. Probably anatomy more than anything, but they just don't. Especially not perforated.
Should have gone upstairs.
Okay.
You still going upstairs?
I don't have the key, but I think Zoe
I don't
would.
push your car.
Okay. Do you want me? Do you need help with any of that, or are you good? Okay.
That'll reassure.
No, I don't think we did.
Well, I'm just telling them if the kid gets it, you should support it. This trip, I have it ready with it. Yeah. Yeah, definitely take a second. Real otitis.
Yeah. Thank you.
Feel better.
Pleasure.
Nice to see you. I'm always an advocate for that. I don't know what happened.
We're always
Thank you.
I get it. Yeah.
I can ask questions over the answer to.